Hello, I'd like to welcome any viewers here with me for this Journal Club presentation done by Amber T. on impact of plant-based diet and support on mitigating type 2 diabetes, mellitus in Latinos living in medically underdeserved areas. One problem we see in the blind rehab where I work is a number of patients present on admission with diabetes retinopathy, as well as repeat admissions due to increased vision decline. It's our job as nurses to assess and educate our patients. If we instill a solid education program with proper nutrition education, maybe we can help to reduce repeat admissions and help our patients to have a better quality of life by reducing these other risks that are associated with diabetes, a few of which you will see here listed on this slide. Now let's discuss what the actual significance of this clinical problem is. The National Eye Institute reported that in 2010, there were 7.7 million Americans that were diagnosed with diabetic retinopathy. And it is projected that in the year 2050, this number is going to double. And did you know that 1/3 of adults with diabetes have diabetic retinopathy? And by the year 2030, there will be 366 million people with diabetes. In the blind rehab unit where I work, we house 31 beds and we have 7 nurses who provide around-the-clock care for the patients. Blindness due to diabetes costs our nation $500 million annually. This is a real problem. Which brings us to the question, what kind of study or evaluation could we do in order to mitigate some of this issue? The PICO question which I have come up with is, in diabetic patients, does diabetic training in diet reflect a lowered result in A1C levels over a 6-month time as opposed to patients who do not receive diabetic training? So you see the population that we're addressing is diabetes. This is the same population which we are addressing in the blind rehab with the diabetic retinopathy. Also, what is the intervention that we're going to be putting at hand? We're going to be intervening with diabetic training in diets. And our goal is to lower the A1C levels, and we're going to give it plenty of time so that people can learn and actually practice this and implement it. So we're going over a 6-month period of time. And what do we expect to see at the end of all this? We would like to see A1C levels reduced in our training group. So I've selected an experimental research study which is titled The Effects of Intensive Nutrition Education on Late Middle-Aged Adults with Type 2 Diabetes. And the purpose of this study that I selected was to test that if intense nutritional training in education would help to benefit diabetics. To give you a little bit more background about this study, it does have a sample size of 196 patients. The ages are between 50 and 65. Average age of the control group was 58.3 and experimental group was 59.1. The gender was split pretty evenly, with males at 51% and females at 49%. And the ethnicity of this group was Chinese. One other thing that was important in this study was that the A1C levels had to be greater than 7 for them to even be in the study to begin with. And the setting of this study was in Inner Mongolia in China. So some research methods, or how they went about this research in the first place, was that the people who were in the intervention group not only received nutritional training, but they also received knowledge about diabetes. They received information on how to put their diets together and plan healthy meals, and also what it means to have a healthy lifestyle. They received training on how to monitor their blood glucose and also medications and the different types of treatments that they get with the medications. They did receive class every single morning for a 30-day period. It does not say how long the classes lasted during the day, and the opposing side, or the control group, just received basic health advice and kind of the principal guidelines for diabetes and a diabetic diet, as what's issued in most cases when people first learn that they're diabetic. So what was our research methods? In this study, we see an overall reduction in A1C of 0.6%. This is a statistically significant reduction, which has a p-value of less than 0.05. And the outcome was measured by starting with an A1C at baseline to see where everybody was starting at, and then also followed up by an A1C that was taken 30 days later when the intervention was completed. Does this study relate to the PCOAT question that I presented earlier? Well, this table helps us to compare that. So it's asking, do the study population and the question population, are they the same? Is the intervention the same for the study intervention and the PCOAT intervention? And also, what's the outcome that we're expecting to see or that we're testing in both of these? And as you can see, they are a complete match for all three areas: diabetic population, nutritional training, and A1C levels. Research study strength. How do we know if a research is actually strong enough to present the information that we would like, or if it's accurate enough? Well, one thing that they do to ensure that they're eliminating as much bias as possible is they use randomized assignments. So patients in this study were randomized by computer using randomized number method. And like I said, the benefit of randomizing is so that we can help to eliminate bias. And randomizing also helps to have a positive impact on internal validity. If we did not use randomization, then there might be some kind of pre-existing attribute that could affect the outcome of the experiment. It could cause us to question, was this study actually valid, or was it just that the patients that were placed into this group had this pre-existing thing that made our numbers kind of skewed when we did our research? And then the next thing we need to look at is the attrition rate. So what is an attrition rate? Basically, it's how many participants drop out or are no longer allowed to participate or can no longer participate in the study for whatever reasons. This had an attrition rate of 2. And when we're looking at, we had 196 people left after the 2 dropped out, that sounds like a pretty good number, but how do we know that that's actually a good number? One thing that they can do is a power analysis. Basically, a power analysis is a statistical test that determines how many people that we would need in a study to have a good representation of a population. A power analysis was performed in this case with an 80% power, and also it allowed for 15% of missing data, and we only had an attrition of 2. So that tells us that we had a significant sample size, or a decent sample size, in order to run our testing. We also have to consider external validity. What external validity is, it's the degree to which study results can be generalized to a setting or samples other than the one studied. One problem with the study that we looked at was that it was conducted on a Chinese population. Why is this a limitation? Well, there might be cultural or ethnic differences in the way that the diet affects them, something that we haven't looked at. It might be that one ethnicity has a different response, or there's different cultural aspects. So this is something that needs to be considered as well. I would like to inform the directors of the blind rehab, nutrition, and nursing of the study results and request a practice change in our facility. Stakeholders in implementing this change would be like the living skills instructors, nursing staff, and dietitians. Everybody would need to come together in order to come up with a program that's feasible and would work with our training program. Two major things that we also need to consider in cost would be the wages for the time spent on collaboration of the program and implementation details, as well as training expenses and materials. In no sense would I ever want to rock the boat, but I propose a pilot be conducted in the blind rehab unit because one of the reasons is that we house patients for educational purposes for a period of time. We already have education on preparing meals. Why can't we incorporate the resources that we have with nutrition, nursing, and the living skills instructors and come up with a plan so that we can help prevent further comorbidities of our diabetic patients by helping to lower their A1C and possibly help prevent further vision loss. 5 key points we need to look at is that we're going to be lowering A1C levels. It's a very low risk intervention that we're doing. It would help to lower the costs of their future medical care, and it will teach them lifelong living skills where they can adapt to their disease to where they can help to mitigate some of the issues that come along with the disease. And it will give them a better understanding, not only by the patients, but the staff will understand better as well, and we will be more equipped to help our patients. So why should we implement this plan on the blind rehab unit? Well, one of the reasons is the patients that are admitted onto this unit are evaluated prior to admission for cognition levels and for overall health levels. So they have to be well enough to where they can withstand the training that takes place on the unit in the first place. This means they'll be able to have an understanding and actually be able to utilize the skills that will be going along with the training that we would be providing for them. We already have living and skills instructors who provide education in meal preparation. We already have nurses that are dedicated to providing our patients with education on better medication management. We already have a dietitian that comes to the unit. So all we would have to do is collaborate these teams and come up with a training format. And the way that we could approach the staff so that we can orient them to this would be like a classroom type setting, where we set aside time so we can work out the details of the program, what education materials are needed, and exactly what goals that we want to accomplish with this. What aspects do we want to cover? And patients could be informed when they come in by being asked, would you like to participate in this program? I see that you're diabetic. Would you like to know how to handle your diabetes better? Then other clinicians would be informed by an email stating that this pilot program was going to take place, what the details were going to be, and then exactly how it might affect them. I would like to see it take place over a 3-month period of time so that we could not only evaluate that they have learned this stuff, but that they continue to utilize the information that they're given. Information would be shared in a 3-month follow-up meeting and then distributed via email from there. In conclusion, I propose that we move forward with this practice change. Let's find out if we can actually help make a difference in the A1C levels of our diabetic patients. Let's find out if we can help to prevent some diabetic retinopathy and promote overall health of our population. Let's make a difference in the lives of our patients.